So from this moment onwards, I will record the presentation. So Dr. Romesh Gunasekara is the consultant plastic surgeon who's working at Lady Ridgeway Hospital for Children since 2000. I think it's nearly 21 years. And I think Malka told me, I think you have done more than 5,000 cleft lip and surgeries and nearly like you do about 250, 300 cases per year at the Lady Ridgeway Hospital. And also he had his fellowship at St. Andrew's Center for Plastic Surgery, Chelmsford in UK, as well as cleft and craniofacial fellowship at Great Ormond Street in 2003. So since then he's been working at LRH, and not only his experience in surgery, he's a great teacher and inspiring teacher. So we all are lucky, like we learn from him, everyone, all the plastic surgeons in Sri Lanka need to learn from him. So you can start, sir. Over to you.
Okay, can you see my screen?
Yes, sir.
Okay, right. So yeah, we're going to discuss velopharyngeal dysfunction, and we are going to discuss this brief outline of what I'm going to talk of. Now, normal speech is dependent upon function, the functional and structural integrity of the velopharyngeal complex. And it's a very finely coordinated and dynamic structure. So the whole idea is to uncouple the oral and nasal cavities during sound production. Okay. And inability to achieve closure will lead, of the velopharyngeal port will lead to the inability to make some of the relevant sounds during speech, and that is what we call velopharyngeal dysfunction. Now, what do I mean by relevant sounds? So it's not that all sounds. So it's mainly the pressure consonants, the fricatives, that are affected by the inability to close the velopharyngeal port. So because the pressure consonants are made by, for the pressure consonants, you need to develop pressure within the intraoral cavity and to suddenly let it go. And during this period, the velopharyngeal port has to be closed. Now, similarly, the fricatives, where those are the sounds that are made with the vocal cavity or the vocal passage partly constricted. So you force it through a part constrictor. So the sounds like sh, z, ch, t, and v. Those are the fricatives. So they also need a functional and a closed velopharyngeal port to be able to make it clearly. Now, usually the vowel sounds are not affected. So a, e, a, e, o, those sounds are not affected, but sometimes they can get nasalized. Now, in VPI or velopharyngeal dysfunction, a lot of the acoustic energy that needs to be released via the oral cavity will get now diluted into partly being carried by the oral cavity and partly being carried by the nasal cavity. But what are not affected are the three nasal sounds, especially in English and more probably in Sinhalese. I think in our language there are more nasal sounds. So I think Malka can elucidate a little more on that, such as M, M, N, and N sounds are not affected. Now, when the term velopharyngeal dysfunction encompasses really three abnormalities. So velopharyngeal insufficiency, which is what the term given for when there is abnormal structure and anatomy. So example wise, submucous cleft palates, where repaired cleft palate, or even the type of the dysfunction you get post-adenoidectomy. Whereas velopharyngeal incompetence is the word that we would use, or the term we would use, where it's purely due to abnormal function or abnormal movement of the palate, which is either neurogenic or myogenic. For example, neurological causes, even cranial nerve problems, or even muscle hypertonias will give rise to, and that term, what we use is velopharyngeal incompetence. And there is one other term, which is called velopharyngeal mislearning, which is thought to be, it's a word that is used to indicate where the palate is normal, structurally, the function is also normal, but it's just that the way it's being used is different. And it's often, according to Malka, it's often seen in children who have hearing problems. Then that is velopharyngeal mislearning. So 3 terms for velopharyngeal dysfunction. Now, from now on, we are going to now concentrate on velopharyngeal insufficiency more than the others. Now, children with velopharyngeal insufficiency will go on to develop secondary speech and behavior patterns. For example, facial grimacing, hoarseness of voice, and compensatory misarticulation. And all this is done to try to minimize the nasal air escape. Now, compensatory misarticulation comes because they're trying to somehow make the sound, which they are unable to do. And what they do is they keep continuing to use areas further back and all the way up to the end. A classic example of this would be what's called a glottal stop. When you can't make certain pressure consonants, they'll try to make it, or even pressure like k, g, and so on. They take it up to the glottis, and then you get a glottal stop or a glottal articulation. Now, in addition to this, sometimes you can get non-speech associated symptoms of velopharyngeal insufficiency, and such as nasal regurgitation, classically seen in submucous cleft palate and so on. And also chronic rhinitis, because of the same reason of nasal regurgitation, it causes irritation, and then you can get a chronic and a postnasal drip. Now, velopharyngeal closure for speech is a separate neurocognitive pathway to swallowing. That's why swallowing can be normal in the presence of velopharyngeal insufficiency. Now, the reason why we worry about it so much is because of the impact it has on the quality of life, especially once they start going to school, or even before, when they realize that they are unable to express themselves to the people around them. They become very frustrated, and that can give a lot of behavioral problems, in addition psychosocial problems associated with it. So even in school, they can be bullied, so they will struggle with work in school. They might even start withdrawing from the social setup. So this is a significant problem, and that's why so much has to be done for this. Now, ideally, the management of this should be done with a multidisciplinary team. Now, usually these multidisciplinary teams are very big. Now, this is a team at the Great Ormond Street, where you can see a whole host of speech therapists there. You can see plastic surgeons, Brian Summerled, Kangesu, myself, clinical geneticists, maxillofacial surgeons, orthodontists, and so on. So it's a huge team because there's so much involved in the management of these kids. Now, obviously, when this child comes to you, it could come either as a complete referral, a new referral from a pediatric source, or it could come from a speech therapy related referral, or probably a ENT referral. But a history is obviously the most important part of what we are going to do. And there are a whole host of things, and I'm not going to run through all of them, but it just shows you how much uh, uh, detail we need to go into to be able to really try to unravel this. Of course, if you're getting a completely new case, and it could be anything, any one of the velopharyngeal dysfunctions, this is really, really important. In examination, these are the things that we really look forward to, look for really. And in this, we will go into the old notes and so on to be able to. So now here, this I have tailored it more for velopharyngeal insufficiency. So particularly the presence and location of any fistulae, submucous cleft, and all notes to where it denotes soft palate length and symmetry. These are all very important because when you're trying to make a management a protocol for this child. Now, in the process of trying to make a protocol for this child, I think the most important part of our assessment lies with the speech therapist or speech pathologist. And it begins with the perceptual evaluation. And the goal of it is, of course, firstly, if it's a new case, to decide is there a disorder? And we depend so much on our speech pathologists to tell us this. Is there a disorder? What type of disorder is it? In that relationship that I talked about in velopharyngeal dysfunction, how severe it is, and what is the possible cause. Now, importantly, we will make a treatment protocol, or we will plan for treatment only if the perceptual evaluation, according to our speech pathologists, indicates there is a problem. Even if our investigations that somebody may have done and sent us might indicate there is a problem, if there is no perceptual evaluation shows there is no problem, then we will not embark on treatment. So that's an important part of perceptual evaluation. Once that is done, we have now answered the question, is it abnormal structure, abnormal function? Now here I'm now confining myself to abnormal structure. So how does abnormal structure affect speech? So clefts of the primary palate only, the more anterior part, there's a risk of dental problems or occlusal problems that can interfere with speech. And those, therefore, are now going to be handled by our dental colleagues and orthodontic colleagues in the team. If the child has a secondary cleft palate, then there is a risk of velopharyngeal insufficiency due to a lack of structural cohesion. Now, investigating this, we rely on these three investigations primarily. Nasometry, lateral video fluoroscopy, and nasal endoscopy. Now, nasometry is not common. We don't have nasometry commonly in Sri Lanka at the moment, but it's commonly used in the UK. And what nasometry does really is that it quantifies what your evaluation, the speech evaluation, has found. Because the problem is that perceptual assessment is subjective. So it's difficult. So inter-rater or inter-observer variation and inter-center variation can be quite marked. So to be able to try to give it a value, nasometry has been used quite successfully. What it does is it captures data, and you can see here how nasometry is done. So there is this plate here. So it captures data from the nose and the mouth separately, and it is able to measure using software the acoustic energy, and that is correlated into a score by using a percentage and comparing it with normative data. And with that, so the Naslund score is a percentage. So the higher the percentage, it means that the higher the the velopharyngeal incompetence, and particularly the nasal emissions. Now, when it comes to surgery and planning surgery, what is more useful to us is lateral video fluoroscopy and nasal endoscopy, because they allow us to get more direct visualization, and therefore both the anatomy and the physiology or the physiology function can be better assessed and for planning of surgery. But the disadvantage is that this data is difficult to quantify, unlike nasometry. So there have been attempts, and particularly there have been now attempts to use MRI as it becomes more widely used, but it's yet MRI is difficult to use as investigation for velopharyngeal insufficiency. Now, lateral video is one of the main investigations that we do, particularly in Sri Lanka, for trying to assess velopharyngeal insufficiency. It essentially is a soft tissue X-ray, a lateral video soft tissue X-ray. Now, currently with the digital setup, we use it at about 15 frames a second, but I really did prefer the more analog systems because they gave a real-time continuous video output, whereas now it's in frames per second, which is can be slightly more stepwise. So if you can make it higher than 15 frames, it's probably better, but what we get is about 15 frames a second. And we are able to look at basically the soft palate and the pharynx in real time. So it's a sagittal cross-section. And during the test, we are going to look at the palatal length, of course, as relative to the rest of the pharynx, length and thickness relative to the pharynx, involvement, the presence of the adenoid tissue, and how much that seems to be involved with closure, or particularly where it might try to close. Then also abnormal tongue movements, where sometimes these children can use the tongue to flick the palate up to try to achieve velopharyngeal closure. The movements of the posterior pharynx and the presence of a passavant. Now, the presence of a passavant ridge is more really it's not very helpful. I mean, sometimes we see it, but it usually is not in a useful place for us to use. But the presence of a passavant ridge sometimes shows how much effort is being used from the lateral pharyngeal wall to try to achieve closure. Then the position of what is the important part is what you call the levator knee or the genu, which shows you, because the genu forms at the point of insertion of the levator, which is the muscle that we are really interested in. And that shows you, therefore, whether it is, but usually it should be inserting around between 2/3 from anterior and 1/3 posterior. That's the usual point where the levator will insert itself. So it helps to now judge, in particularly a repaired palate who is having velopharyngeal insufficiency, where this is, and that will really be a major factor in our algorithm that we are going to use. And also the closure. Now, I'm just going to, this might be a bit too loud, so let me just reduce the volume. So now this is you can see here the movement. Can you see the movement of the, there you are. That's the movement, as you can see the big gap between the posterior pharyngeal wall there. Let me just stop there. So that's the posterior pharyngeal wall. That's the that's a genu here forming. So it's around the middle of this, and in fact you can see a Passavans ridge also forming just in front of that. Let's see if I can stop it there.
May I ask one question? Sorry.
Yep.
Is this Passavant ridge present in normal individuals as well, or just we can just see it on the patients with the clefts or VPI?
What's that? The genu?
No, the Passavant ridge.
Yeah, sometimes you can see in a normal person as well.
Okay, we can see it on the normal. Okay.
I think in this patient, I just about saw it, but it's see. But what's important is when the Passavant ridge forms, it is too low. It's much below the point. The Passavant ridge is forming somewhere there, and you can see the palate is trying to close much higher on the posterior pharyngeal wall. So it's not going to be very useful. And now this one is bad palate, and you can see there you can see it going and touching the posterior pharyngeal wall. And if that's where the Passavant ridge is forming, and that is where the closure is taking place. Yeah, you can see a very prominent genu forming, and there's another there again you see a short palate where there is a large gap between the, you can see the gap there. It's smaller gap than what we saw before. And in this, and you can see a very prominently forming genu there and touching the posterior pharyngeal wall almost. There you are, it's touching the posterior pharyngeal wall. So this is how our lateral video fluoroscopy helps us in arriving at a diagnosis and, of course, planning information. Now, nasoendoscopy is our second most important method, and we usually use a fiber optic nasoendoscope. Ideally, I think it should be about 2 millimeters, because but from 2 to 3.5 millimeters is the usual size that is used, and it comes with a cold light source. And now the newer systems come in a chip-in-tip type of endoscopes, and so they're very much better than what it used to be, and much more handy to use. Now, how? Just let me go back to the lateral video fluoroscopy. That's now the important. So we have the machine turn. Now this is the usual bed. So we turn it vertically up, and we have the X-ray tube coming at you from lateral side. And usually the children love to sit. Now, what we used to do in Great Ormond Street is that we used to attach a little piece here with the what's called the what is it called? It's the little thing that you can see pictures on. So we attach it to that, and we get the children to look through that, so that they keep their head very still. And that was a really fantastic innovation by the speech therapist at Great Ormond Street. And they also can add a little ring, which is radio opaque, therefore, with a little wire ring at the just above that. So that can be used to take measurements, because the ring was exactly 1 centimeter. So that in still photographs, we could therefore make measurements. So we need to use topical. Now, depending on the unit who's doing it, the protocol changes from minute to minute. The way I would do is to use, we will use topical anesthesia, and it's useful to use nasal decongestants. We use lubricating gel, and you discuss the procedure with the mother and the child, and sometimes you need to restrain the child. So what we do is, now one of the biggest problems I have when I'm doing nasal endoscopy is when we use lignocaine, and that is 10% lignocaine, the usual spray that the ENT surgeons use, and unfortunately that is quite stinging on the nose, and the children react quite badly to it. Now, the other way to do it is to take the topical anesthetic solution, like a 4%, the topical solution, and get it into a syringe and introduce it with a little feeding tube with a little bit of cotton wool wrapped right at the end of the tube. You just introduce about a centimeter into the nose. What we want to do is only to anesthetize the most anterior part. So the anterior turbinates and the most anterior part of the nasal cavity. What you don't want to do is to allow a lot of anesthesia, topical anesthetic, to run down the palate and anesthetize the pharynx, and sometimes maybe even if it gets absorbed, to paralyze the palatal muscles, and that can happen. So you only want the anterior part anesthetized just to be able to introduce your endoscope. Nasal decongestants are useful, like Afrin is useful because it can cause contract the turbinates, the erectile tissue of the turbinates to constrict, so giving you a little ability. So you go through the middle wall, and above the inferior turbinate and below the middle turbinate, and so therefore when it constricts, it gives you much more room to introduce it, and you introduce it with the lubricating gel. Now, the children tend to move around. As soon as you try to put it in, they move their head. And to try to stop that, it's useful to get the child to sit with the mother, and the mother to hold the child's forehead against and push the head against the mother, which will then steady it on the mother. So those are little useful tricks that we can do. But I find that the earliest that I can do it in Sri Lanka is at about 5 or 6 years. Before that, they are just too terrified. I think the person who's most useful in getting this done is our speech therapists, because they are the ones who have been having a lot of contact with the children from the time we have operated at 1 year, and when we are trying to do it at 5 years, and they have a much better rapport with them. So that helps us to calm the child. And what we ask our speech therapists to do is to discuss the procedure for a long time, and then we get them down to the clinic, and best is to discuss it with them for a little while before trying to do. If you try to go slap bang and try to do the procedure, they will not allow you to do it. Now, at Great Ormond Street, the speech therapy there was sometimes able to do it on 4-year-olds, but I think it's very, very difficult. And even in a 5-year-old, a 3.5 millimeter endoscope is way too big. And I think about a 2 to 2.2, which is a bit difficult to find. 2 millimeters is pretty difficult to find, is the better option. Now, this is what the endoscopic view looks like. And this is the base of the velum. This is the upper surface of the velum, and that's the velopharyngeal orifice. And this was described by Croft, and they saw 3 patterns of velopharyngeal closure, which they call coronal, sagittal, and circular. And they said the commonest closure pattern is what is called a coronal. And here the velum has to lift up and touch the posterior pharyngeal wall for closure. Whereas in the sagittal closure, there's a lot more movement of the lateral pharyngeal walls. And in a circular closure, there's both posterior and lateral movement in addition to the, but there is less movement of the velum. Now, this is possibly why, where sometimes even a palate which doesn't look as if it is closing very well is producing pretty adequate velopharyngeal closure, is because the lateral pharyngeal and posterior pharyngeal wall is able to compensate for it. But this doesn't happen in everybody. The commonest closure pattern is coronal. Now, certainly there are certain advantages and disadvantages in the two systems. The biggest advantage in video fluoroscopy is that firstly you can see the tongue movement, okay, and the entire posterior pharyngeal wall is very clearly visible during speech. And one of the most important things is that it's much easier to perform, and the children are way more cooperative for video fluoroscopy than endoscopy. But on the other hand, nasoendoscopy gives us way more information, really. And these are, I'm not going to go through all of these, but these are some of the things that are really useful. And a rather important point here is what I have outlined here. Now, in patients with velocardiofacial syndrome, there can be a small percentage of them who have medially displaced carotid arteries. It can happen in others also, but it's more common in velocardiofacial syndrome. And this can be a very important consideration when we are going to discuss our velopharyngeal procedures for management of the insufficiency. So there's a lot more that we can learn from nasopharyngoscopy, although it is much more difficult to perform. Now, once we have done this, I use this algorithm, and this is from Brian Summerlad, and this is the algorithm I use because I think it's very simple and very clear. And I'll just run through it to tell you what it means. So when you do a lateral video fluoroscopy, particularly, if your genu is forming anteriorly, it means your levators are anterior. Now, if when you look at it, there's a lot of length behind the place the genu is forming, and it potentially looks as if there's adequate length, then what we would do is a re-repair. And of course, our endoscopy also would help us to make that decision. And what I would simply do is a re-repair of the palate as the first step. But if definitely it's inadequate and is looking short, the levators are anterior also, I will go for a buccinator flap or buccal flap and a re-repair simultaneously. On the other hand, if the levators are posterior and there is yet velopharyngeal insufficiency, but there is good velar mobility, and if the appearance of the palate is not good, the anatomy is looking short, and it's not very it's not likely to be able to extend backwards, my first consideration would be a buccal flap. But if it is mobile and the anatomy is good and it seems to be having only a very small gap, like 3 to 4 millimeters, then a Heinz pharyngoplasty would be our choice. On the other hand, where there is poor velar mobility, but there is some velar movement, meaning there is some velar potential, then a buccal flap is what I would choose. But if there is no movement, like sometimes what we will see with, very bad 22 Q11s, then you might have to think of like something more like a prosthetic device or even a midline flap, although it's not my first choice at all, the midline flap. So that is about the algorithm I use to decide what I'm going to do. And as far, yeah.
I have one question, sir. Like, suppose we think that the genome is anterior, and this patient has already undergone clip palate repair previously, and do you still reoperate them?
If the liver is anterior and I haven't operated on it before,
Yeah.
I will, yes, do a re-repair. But if I look at my notes and I think that the repair that I have done is the best I can do, and then I would then decide to do a buccal flap.
What is the repair you do? You do it against Summerlad or the
Summerlad. Yeah, I would do Summerlad. I rarely do a furloughs, but there are times I do furloughs as well. But my primary thing would be a Summerlad. Yep.
Okay, thank you, sir.
So now, so as far as when you consider the management procedures that we can use, so for non-operative, we can either have non-operative for a few, very small percentage of patients who probably ones who have had, they are not suitable for surgery or they are, have development delays due to other problems. We can think of non-operative procedures, which I will briefly discuss later. And of course, we have the operative procedures, which you look at in as palatal, palatopharyngeal, and pharyngeal procedures. Okay. Now, these are the non-operative appliances that can be used to help to lift up the. Now, this is a speech bulb, and this sits up here and lifts up the palate and also causes obstruction at that point. So physically reducing the velopharyngeal orifice, creating a closure. Sometimes tolerated fairly well. Now, obviously, you can see this patient is unrepaired palate, must have been very much older patient who's able to tolerate a speech bulb. And some people can tolerate it well, but there are plenty of others who find it very. This is another type of device, and this, again, another speech bulb. And this speech bulb is really a device that is only lifting. It's not causing obstruction. What it's doing is it's just lifting up the soft palate so that it allows whatever movement that is there in the soft palate to close the velopharyngeal port. So those are the non-operative procedures that we can use or devices that we can use. These are all different types of. These are speech bulb, and these are lifting device. Now, when it comes to now, another important point is the fat injection to augment the posterior pharyngeal wall. Now, this was around the late 90s and early 2000s. This became, when fat injections was becoming popular, people thought of using this, but there have been disastrous complications of fat embolism, and I know it happened in Cambridge, and there was a huge outcry at that time, and I think it's been largely given up. The procedure of injecting fat into the posterior pharyngeal wall. People are yet injecting fat into the palate itself, but because especially when it's a very thin palate, some have obtained some fairly good results by injecting fat into the palate itself. But as far as the posterior pharyngeal wall, because if you get it into these retropharyngeal veins, and that's the time you get a fat embolism. So it's not considered a safe option anymore. But you will see plenty of, there will be journal articles, there will be, different reports from different parts of the world, which will talk of fat injection as well. That's why I just want to tell you the danger of it. Now, the primary goal of surgical management is to produce a competent velopharyngeal mechanism. Okay, but in doing so, the most important consideration is also that we need to avoid nasal airway obstruction. So these two are sometimes not mutually exclusive. You can't sometimes avoid the other when you do one. Okay, so sometimes those are the things that will fine tune the real process, that the procedure that we are going to do. And as a surgeon, what you will do will be, I think, dominated by what problems you have had before. Now, as far as palatal procedures go, the procedures that we will embark upon are, first of all, often the first thing I would do for a patient whom I have not operated on before will be a palatal re-repair, because of the fact that I know majority of surgeons who are doing it will not repair the levator the way we do it in a Summerled repair. So trying to posteriorize the muscle sling, the levator sling, is the best procedure. But of course, remember, I use the algorithm. The second possible procedure is a furlough repair, double opposing Z-plasty. Now, it is usually when the distance. Now, there have been many reports of excellent results for VPI using furloughs repairs, but usually what it can achieve is about a 5 millimeter lengthening. Okay, and it's not always easy when you have very thin attenuated tissue, especially the nasal layer tends to just tear so easily when you're trying to do a furlough repair. So I do a few furloughs, but it's not my first choice procedure. Now, the buccal flap certainly is a procedure that I like very much, and it has seen, I have been doing it over the last about 10 years now, and as you improve the surgical procedure, it becomes a very easy operation to do. It here takes at least 2.5 hours, because the amount of suturing that you need to do finally, but it's a good procedure. Now, so when it comes to static procedures, pharyngeal or palatopharyngeal procedures, we can classify them as static or dynamic procedures. Now, the static procedures are the inferiorly based pharyngeal flaps, which are now rarely done. The commoner one is the superiorly based pharyngeal flaps and a laterally based pharyngeal flaps, and I'll go into that a little later. And the dynamic operations are the Heinz and the Orticochea type of pharyngoplasty. As I said, whenever you are doing a pharyngeal or palatopharyngeal procedure, you must always look for the abnormal anomalous carotid arteries. You have to keep this in mind. And I have seen it twice up to now, but not on patients that I have had to do a palatopharyngeal procedure, but just while operating for the palate. So, because it can have, and there have been disastrous consequences of damaging, of course, the carotid artery, but it can be done even in the presence, but you got to know that it's there, and you got to be careful in how you get into the posterior pharyngeal space, because it is separated from the superior constrictor and so on with a lot of other tissues. But you need to know that it's there and be very careful how you go about it. Now, the complications of most of the pharyngeal and palatopharyngeal procedures are that obstructive sleep apnea is the most difficult complication to handle. And of course, there's very much a tendency for bleeding, which is much more than palatal surgery. And certainly reactionary bleeding can be a problem. So achieving good hemostasis is, I think, vital. And one of the biggest problems is, now what I have done many superior based pharyngeal flaps, and almost all of them develop obstructive sleep apnea. And one of the biggest problems in a country like ours, in the Southeast Asian region, where we use a lot of rice, is that food particles like rice can easily get in through these two narrow pharyngeal ports that we have created. So we have, instead of having one pharyngeal port, now we are creating two small pharyngeal ports, trying to reduce the nasal emission. And rice can get in there. It's so difficult to get it out. So they complain a lot. And it's a very unphysiological operation, because you're really tethering it down to the pharynx. The velum is being tethered down to the pharynx. And although we take a 1.5 centimeter flap and we try to, we measure and we can decide on, keeping these ports which have a certain cross-sectional area, once it contracts down, they do get very narrow. And sometimes it pulls it in so much that this 1 centimeter, 1.5 centimeter pharyngeal flap you use becomes just a cord, which is not more than about 4 to 5 millimeters in diameter. So it can be a very unphysiological operation. So that's why I don't do a superiorly based pharyngeal flap unless it is in the most mitigated circumstances. And the technique is, that's the technique. So we create a flap in the midline, and you need to go as far down as you need to be able to come to. So to do the pharyngeal flap, you need to open up the velum. Without opening up the velum, you cannot put the flap as high up. Now, see, can you see we are trying to go as high as possible, because otherwise I have seen many superior pharyngeal flaps which the base can be seen when you open the mouth. That cannot be the correct position. It's got to be much higher up. It's at about the arch of the atlas level. It's got to be higher up at that level. And to be able to achieve that, it's best, and anyway, in superior pharyngeal flaps, you need to open up the velum, you divide it into two, and you develop the pharyngeal flap, you close the donor site, and now you insert this tip of the flap to that point. And you can see that therefore the mucosal surface therefore goes to the nasal side. And the oral surface now is therefore just exposed muscle. And to be able to cover that, what we do is we make an incision. So we have made an incision here. So there's it's open here. We make an incision on the nasal surface running up that way onto up to the margin of the velum. Okay, like that. So make the cuts that way. Okay, on the nasal side, and you unravel the nasal part of the nasal surface of the velum in that direction. Okay, so that this point you will attach it to this, and you will suture on the side so that this exposed surface now will be covered with the epithelial surface. Now, is that clear? It's a mucosal surface. Now, is that clear what I'm saying? Especially
yes. So I just wanted to ask one question, like when you divide the velum, you divide the muscles as well, right?
Yeah.
So then it doesn't do the function that it's supposed to do, right? We don't have in the posterior flap, we don't have any muscles, it's just a mucosal flap.
That's why I said it's a bit unphysiological.
Yeah, okay.
Yeah. Okay, so whatever, once you put this flap in, lifting of the velum is levator functions are not going to be able to be used very well. Okay, because of the fact that it's now gone more laterally. It doesn't lift up so much. There will be some function, but not much. Okay, So that's a superiorly based pharyngeal flap. So when you're closing up, you need to get very good hemostasis here, because these can bleed later. And as you can see, it's very difficult to get at it. Okay, so it has to go to theater. It's very difficult to see without good retraction. The final point here, the most distal point, is sometimes very difficult to catch. Now, the inferiorly based flap is even more difficult, because if you were to do a flap that is somewhat effective at all, you got to take it from way high up here and to have your base at that level. So you can imagine how difficult it is going to be to approach this, and the chance of this having problems with bleeding is way more, because this pharyngeal, the nasopharyngeal area is not as elastic to be able to bring it together. It's not very mobile. Whereas the lower part of the pharynx is a bit more mobile, so that you can yet primarily close it. Okay. So inferior based flaps are rarely done. So it's a superior based flap which is commonly done. So the next procedure is a laterally based pharyngeal flap. Now that was a superior midline pharyngeal flap, and this is a laterally based pharyngeal flap, and this is really a fairly useful procedure for a few cases, very few cases. Now this is just giving you the options, okay, in where you have a asymmetrical palate, where one side is shorter than the other side, like that. Yeah, so that's this side is a very short asymmetrical palate, and to try to get this to lengthen, you can use a flap of, really this flap incorporates the salpingo pharyngeus, okay, and you can make an incision on the nasal. So to do this, you need to again divide the velum to be able to get access to this. You will probably repair the muscle and do a intravelar veloplasty type of operation, like Summerled type of repair of the levator. And once you have done that, once the muscle has, once you have dissected the muscle, you'll make an incision on the nasal surface like that, and insert this flap onto the nasal surface. That helps to elongate the short asymmetric palate. So the laterally based pharyngeal flaps are useful only in this sort of circumstance. Very few subset of cases, but it's just another operation that we can have in our armamentarium. I have probably not seen more than about 2 or 3 cases after seeing about 5,000, 6,000 cases. So it's a bit uncommon. But Brian Summerled, I know, presented a paper where he had done 12 cases. Of course, Brian has seen way more cases than I have. Now, the other procedure, which is it's a pharyngeal procedure, is a Heinz pharyngoplasty. Now, the purpose of the Heinz pharyngoplasty is when there is, as we looked in our algorithm, where you have a mobile posterior levator, but there's a small gap to close. It's unable to reach the posterior pharynx, but with just a small gap, maybe just about 3 to 4 millimeters gap. Then a Heinz pharyngoplasty is a useful procedure, but it is not the easiest of procedures also. Now, the Heinz pharyngoplasty, in comparing it to the Ottikocha type of sphinctopharyngoplasty, the place where you use the flaps are different, and the reason you use it for is different. The Heinz pharyngoplasty is only trying to create a physical bulge in the posterior pharynx where you are expecting your genu to touch. Okay, and in that context, it has to be, like I showed, like we looked at in the superior pharyngeal flap, it is very, very high up. Comparatively, it's almost at the level just slightly above where the C1, the body is, okay, the atlas body. It's just a little higher than the atlas body itself. So it's and you can get an idea of where this is going to close when you do your nasoendoscopy and also your lateral video fluoroscopy. So you develop two flaps, and again you develop this just outside the salpingopharyngeus, and you leave about a 1.5 centimeters on either side of the midline for your the more medial incision, and the flap itself can be 1 to 1.5 centimeters, 15 millimeters. It's a pretty big flap. You develop the two flap and you connect the medial incisions of the two flap across this with this transverse incision. And the idea is to put the two flaps like that to form a bulge. It is not about just bridging it. It's about allowing it to just bulge out. And when you finish this, so these are the two flaps developed, closure of the two defects, and you now overlap these two muscles in this way, but to achieve this bulge. So if you create a defect and you put it, it's not going to create a bulge. You just need an incision, just separate out the incision a little bit and you put it together, and then it will create this type of bulge, right? And the most important thing now, in fact, this drawing is really a deceptive drawing. This is not where the bulge should be. The bulge should be there, okay? That's where this genu is going to come and close. Now, what they have drawn here is here, somewhere here. So you can see how people, when they are making their drawings, how they can make inaccurate drawings as well. So that is the principle of doing a Heinz pharyngoplasty. Now, in comparison to that, the oticochea takes its flap from the posterior pillar of the fauces, okay, where the palatopharyngeus is running down. So you're taking a flap of palatopharyngeus, then you're overlapping it and tightening it across, right? You're tightening it across. So this is salpingopharyngeus, and that's the posterior pillar of the fauces, and that's where your palatopharyngeus is going to be. So you're going to tighten it so that the lateral pharyngeal walls will come closer, and that's the idea of a sphincter pharyngoplasty. So you tighten it, you shorten it as you overlap it as much as necessary, and that's for that. Now I will just run through the steps of a re-repair, but I'm going to use isolated cleft palate. These are the photographs that I had, because it is almost identical. So this is the markings. So if it was a complete palate, you would just mark the midline, and then you start lifting up the two oral palatal mucosa and between the mucous glands and the muscle, and that's what it looks like. And once you're finished, this is what it would look like with your muscle now quite anteriorly placed. As you can see now, this what you're seeing really is palatopharyngeus, but the main thing is that you can see that this part is empty of any muscle. So the levator is not seen here at all at the moment, because the levator is going to be under the palatopharyngeus. Next, now you start dividing the muscle, and you will, once you have divided, you are going to use part of the palatopharyngeus for your suturing, but you will selectively dissect the levator to be able to unite it in very much more posterior. And really we are exaggerating the posterior movement of the palatopharyngeus. Normally, the levator velopharyngeal. Normally, the levator would be at about that level, 2/3 from here and 1/3 posteriorly. But here we are even putting it slightly more posterior to try to give it adequate chance to close the velopharyngeal port. That's what it looks like. So that's the same steps I would use if I'm doing a palate re-repair. But the difference is that it's already dissected palate. So therefore, until you get quite laterally, the plane is not very, you have to go creating the plane very carefully, very slowly. And it's quite a difficult dissection. And often what I find is when I trying to find the correct plane, when I push with my blade, kept perpendicular, and when it comes across already scar tissue, it seems to cut into scar tissue better than just trying to cut in and create a plane. Pushing tends to find the plane better. Hopefully, if I have not done the first repair, the lateral areas will be more or less untouched, which makes it much easier for me to find the levator. So that's as far as the re-repair is concerned. The next procedure that is a furlough double opposing plastic. Ideally, it works really well. I must say, even for a re-repair, it does work quite well. Now, when the furlough repair was designed, the way it was designed and way it's described is that, so there are two Z-plasty, and they are going to be opposing, because so this Z-plasty falls against that Z-plasty in the nasal layer. And the principle is that the flap moving back should carry the muscle. That way you don't make the wrong decisions. So for the oral layer, this flap is the one that's going to move back. So therefore you'll keep the muscle, all the muscle on that flap. For the nasal layer, which is like this, the flap on your right side is the one that's going to move back. So therefore you keep all the muscle on your the right side flap. So remember the edge is the flap moving back keeps the muscle. Okay, that's the way. Now people have now modified the procedure, and there are some people who would now do a more of a Summerlet type of dissection for the muscle, unite the muscle, but do a double opposing Z-plasty for the two mucosal layers, which is not exact. It's a modification, of course, of the furloughs. Now, as I said, the buccal flap is one of my more favorite operations now. It's one of my stock operations for Velopharyngeal incompetence. In many of the cases, I find this works correct in my algorithm. And so the important, the practical points in doing a buccal flap is, first of all, you have to look for the papilla. And always mark your papilla with a little bit of ink so that you will not miss out on it. Okay, cannot afford to have the papilla in your flap. That's going to be quite a bit of a problem. We can take up to about 1.5 centimeters. I have taken 1.5 centimeters without big problem. If you're using it on an older person, the third molar may be already erupted. Sometimes even this in younger children, especially in Sri Lanka, a lot of jaws are inadequate for the third molar. So even the second molar sits quite far back. And if you think it is going to impinge on your pedicle, then you might have to use a bite block glued onto the molars to prevent it being bitten for a while. Not the most comfortable thing, but then you need to go and then divide your flaps in about 3 to 4 weeks to allow it and remove the bite block. But the younger children we do, often I don't have a problem because they are edentulous in the posterior part, and that doesn't cause, up to now, it doesn't cause any problem other than one patient who developed a bit of like a granuloma there, which I had to go and just cauterize, and that's it, settle it. So I haven't had to divide many of them at the moment, but in future, as their teeth erupt, we might have to. These are the steps. Now, the buccal flap is likely based on the buccal branch of the maxillary artery, which enters the buccinator on the outer side of the buccinator, but it also possibly gets a branch of the facial artery as well. But when we are developing the flap, most probably it relies on that, and it's not a random flap. It can be considered to be a axial type of flap. Now the steps are, first thing I do is to divide the palette to see how much movement I need. Okay, how much thick width I need. Now, what I feel is that once you divide it through and through, and the palette immediately springs backwards. Okay, that's where it wants to go. Now, there is no sense in putting a flap. If this is only 1 centimeter, there is no sense in putting a flap 1.5 centimeters, because this flap is not a spacer. It is not going to push the palette back. So there is absolutely no sense in trying to push it to put a huge big flap on a narrow opening. So I tailor my flap according to that. The flap can almost come up to, that's the modulus there, almost up to the modulus. And you start developing it from the tip here, get up to the buck. And at this point, really, it is the orbicularis that is there. It's not the buccinator. Buccinator will be found somewhere there. So you take whatever muscle that is there and reach into the, get into the fat plane, and then you develop it just over the muscle or on the outer side of the muscle between that and the fat, and you develop it right at the back there. And then as you see the buccal fat pad becoming visible, then you know now you're in this area where the vessel is now going to get onto the surface of the buccinator, and you need to be a little careful there. Try to preserve the last part, but often, now this is a lower jaw, you need to do for it to swing to the other side, you need to do a little further dissection on the lower part and not the upper part so much. So that's what constrains the buccal flap from moving. So once you put that, and that's the type of flap, and sometimes I can get it to come all the way up here. I use 2 flaps on either side. There are other people who use only 1 flap, and sometimes some people might do like a Z-plasty on the nasal surface and only put it for the oral surface. I prefer to use it on both sides. It does mean that it's a bit thick in the middle there, but the final outcome is very, very satisfying. And it's amazing the amount of what you put as 1 centimeter, sometimes it can even get bigger than that if the levators are pulling adequately well, pulling the muscle up and backwards, then it will even stretch beyond that. So it's really, really useful operation to do with very satisfying results. So that's some insights onto what I do for velopharyngeal incompetence or insufficiency, really. And are there any questions that on the technique that I can help with?
I have one question, sir. Can you go back to the autoteachers slide?
Yeah. Yeah.
So I still trying to figure it out what is the difference between the Heinz and this one, because we recently did one.
Yeah.
We use this lateral wall that includes lateral wall as well as the posterior pillar. So that includes both the superior constrictor as well as the salpingopharynx. And we put it into the midline and like you create the artificial basement ridge, and what usually what is like the Heinz one. But in here, what is the difference between you're creating the ridge? What is the difference between this one and the Heinz one when creating this ridge or the posterior wall?
Yes, look, if you're taking any part of the posterior pillar, that's palate-pharyngeal tissue, then it's not a pure Heinz. And the problem I would see here is, as long as you're connected to the posterior pillar, you're putting the Heinz is depending on narrowing the and bringing the lateral pharyngeal wall closer. Okay, so it's a sphincter action that is trying to create, bringing it narrow, making it narrow. So it doesn't really depend on the touch position. Yeah. Now, if you are taking the posterior pillar, you are going to be limited by the point of the posterior pillar where it comes up to the palate. Whereas when you're doing a Heinz, you are going way above that. The Heinz, you're going way above the level of the palate.
Okay.
And really, you're not even using the palatopharyngeal, the salpingopharyngeus. You don't use the salpingopharyngeus. Okay.
Yeah.
So this sounds now
that's only superior constrict only then.
Mainly, maybe you might catch a little bit of the palatopharyngeus as it inserts into the superior constrictor, but mainly the superior constrictor.
Okay.
And it's for no muscle action, just for bulk.
Right.
Yeah.
Yeah. Okay. So is anyone?
Unfortunately, it's a difficult operation to film video.
Yeah.
Because of course I will do the Heinz in the microscope, which makes it really gives you much better light. Really, that's the most important thing. And of course, if you're doing a re-repair at the same time, that is way more useful. Yeah.
Yes, sir. And one other question, when you're creating the posterior pharyngeal flap, how do you decide what is the width that you take by looking at the nasal endoscope view? Whether it's
usually it's about 1.5 centimeters. I don't now what there are certain proponents of the superior base flap who have gone into a lot of details on measuring how much you want to close and then deciding on that. Okay, so they have an algorithm for that. Okay, they think this amount of closure that we need to get for this person's velopharyngeal closure, and then there is a algorithm which because I don't use the flap much, I don't use it at all. But at the time I was using it a lot. We just use about a 1.5 centimeter flap. I didn't depend on an algorithm or calculations. Okay.
Yeah. And how do you overcome complications if you get this obstructive sleep apnea or anything during post-operative period?
Post-operative period, early phase, you can have like a nasopharyngeal tube. Okay. You can like what we do, nasopharyngeal airway. Immediate, you can put, if you are expecting it, you can put it during surgery itself so that it sits just below the level of that. Okay. Later on, that's in the immediate period, but most of the time that is due to the swelling and that will settle down. And I certainly would use some steroids for them. That will settle down. But in those who are going to have, and papers show up to about 38% will develop obstructive sleep apnea. Okay, if you develop obstructive sleep apnea, that's a bigger issue there. And sometimes CPAP might help. But if nothing else, now I reversed. I had done about 12 or 14 pharyngeal flaps at that time, and I had reversed at least 6 of them. And reversing a flap is pretty easy, really, operation. All you do is to just leave enough of the flap on the wheeler. Okay, you cut it off right at flush with the pharynx, the posterior wall of the pharynx, and that reverses the sleep apnea very effectively. And strangely enough, there is enough evidence to say that whatever velopharyngeal closure that has been achieved seems to persist. And in those, so they don't become velopharyngeal insufficient immediately after. So whatever that you have achieved. And one of the other problems is, of course, hyponasality. These people often have hyponasal voices, okay, speech. And that also reverses very well with once you divide it. So that's for obstructive sleep apnea. But just early obstruction, you will manage with airway.
And have you tried on non-clip patients doing pharyngoplasty?
No.
No.
Okay. But yes, in a patient who's a non-clef VPI with a very poor pharyngeal movement, velar movement, well, there is not much. I have done muscle repositioning, but when you try to reposition muscles, you can see that they are pretty hypotonic. So the chance of that being useful is also not very good.
Okay.
Say for like 22q11 with hypotonia, doesn't respond very well with repositioning. So in those cases, it might, by creating a very obstructive type of procedure, you will get less hypernasality, but at the risk of all these other problems. But remember, when you're now in a like a 22q11, you're already hypotonic, and we know when in sleep we become even more hypotonic. Eh? So that leaves the possibility of obstructive sleep apnea, the greater chance of getting obstructive sleep apnea.
Okay. Anyone else? Prakash, nice to meet you. Prakash, are you there?
I think he's muted.
Yeah, no, so I'm listening. In enrolled children, we did all 3 procedures, but it's actually what you said is correct. Sometimes there are people, they are proponents of superior base pharyngeal flap. Some will do the further. It's kind of a practitioner based rather than algorithm to that. But you said you started with pharyngeal flap and now you have converted to the buccal flap. So what made you to make that decision? Why you converted from the pharyngeal to the buccal flaps?
Yeah, as I said, the 3 things that bothered me most with the superiorly based pharyngeal flap was, one is obstructive sleep apnea, which is very, very disabling. The second thing was they used to commonly complain that rice used to get into their nose and they find it very hard to get it out. And then suddenly it comes out and it's putrefying and very smelly. And the third one was whenever they get a cold, and that was almost in all of them. Whenever they develop upper respiratory infection, they are completely blocked, hyponasal for days, which was very, very disturbing to them. So that was one. And really, I did most of my pharyngeal flaps before I became a consultant, when I was a trainee, really, when I was in my last part of my training. And once I had gone to, been at Roman Street, and again, I guess it's just the influence that you realize, okay, I think this is a better option. And certainly, even a buccal flap, all procedures for VPI have the potential to cause obstruction, depending on how much you narrow or how much you fill up the posterior space. But certainly buccal flaps have a much less, buccal flaps and hind pharyngoplasties have much less chance of doing so. And up to now, I haven't had a obstructive sleep apnea problem with any of the buccal flaps.